Systematic approach to interpreting an arterial blood gas. Welcome to this episode of the Everything Surgery podcast, where we delve into the essential skills every clinician needs. Today, we will walk through a structured and methodical approach to interpreting an arterial blood gas. This 7-step strategy ensures accuracy and clarity, minimizing errors and maximizing patient safety. Remember, always begin by confirming both the fraction of inspired oxygen and the clinical scenario of the patient. Step 1. Assess the patient and sample integrity. The first step is to revisit why the arterial blood gas was performed. Was it due to respiratory distress, a change in mental status, sepsis, or another clinical concern? Next, identify the patient's oxygen delivery, whether it is room air, a nasal cannula, or a ventilator, as each delivers different amounts of oxygen. Confirm that the sample is truly arterial, which is typically bright red and collected from a pulsatile source. Lastly, ensure the analyzer corrects for temperature, as both hypothermia and hyperthermia can influence the solubility of gases and skew the results. Step 2. Analyze the primary acid-base status. Turn your attention to the pH value. A normal pH falls between 7.35 and 7.45. If the pH is less than 7.35, this indicates acidemia, meaning there is an excess of acid or hydrogen ions. If the pH is greater than 7.45, we observe alkalemia, where there is a deficit of acid or an excess of base. The key rule to remember is that the human body never overcompensates, so the direction of the pH tells you the primary disorder. Step 3. Determine the primary respiratory component. Next, examine the partial pressure of carbon dioxide. The normal range is 35 to 45 millimeters of mercury. When the value is above 45, the lungs are retaining carbon dioxide, indicating respiratory acidosis due to hypoventilation. If the value is below 35, the lungs are removing too much carbon dioxide, resulting in respiratory alkalosis from hyperventilation. Remember, the partial pressure of carbon dioxide is controlled by how well the alveoli ventilate. Step 4. Determine the primary metabolic component. Assess the bicarbonate level, which should normally fall between 22 and 26 millimoles per liter. You may also see base excess, with a normal range from -2 to +2. A positive base excess, meaning greater than +2, points to metabolic alkalosis, often caused by a loss of acid such as with vomiting or a gain of bicarbonate. A negative base excess, less than or equal to -2, indicates metabolic acidosis, which can arise from lactate accumulation, ketoacidosis, renal failure, or the loss of bicarbonate through diarrhea. Step 5. Assess for compensation. The body naturally tries to return the pH to normal. However, compensation is rarely, if ever, complete, except in some chronic respiratory disorders. For metabolic acidosis, compensation occurs through respiratory alkalosis, where the patient hyperventilates to lower the partial pressure of carbon dioxide. In metabolic alkalosis, compensation is by respiratory acidosis, with hypoventilation increasing the partial pressure of carbon dioxide. In acute or chronic respiratory disorders, the kidneys adjust the bicarbonate levels, but this renal compensation takes time. If the compensatory response matches what is expected for the primary disorder, it is a simple acid-base problem. If not, you are likely dealing with a mixed disorder. Step 6. Assess oxygenation. Now, evaluate oxygenation using the partial pressure of oxygen and the oxygen saturation. Normal values are 80 to 100 millimeters of mercury for the partial pressure of oxygen on room air, and the saturation should be greater than 94%. To check the efficiency of gas exchange, calculate the alveolar arterial gradient, which compares the amount of oxygen in the alveoli to that in the arterial blood. An increased gradient suggests a problem with the lung tissue itself, such as pulmonary embolism, pneumonia, acute respiratory distress syndrome, or fibrosis. These cause ventilation perfusion mismatch or shunt. If the gradient is normal, hypoxia is likely due to hypoventilation or low inspired oxygen, such as at high altitude or during an opioid overdose. Step 7. Synthesize and generate a full statement. Bring all your findings together in a concise statement. For example, you might say, "This is a simple metabolic acidosis with partial respiratory compensation. There is no evidence of hypoxemia, and the alveolar arterial gradient is normal." Use this structure to clearly communicate the results and your interpretation to the rest of the clinical team. Quick reference techniques and mnemonics for those who prefer visual frameworks. The tic-tac-toe method is a helpful way to align the patient's values for pH, partial pressure of carbon dioxide, and bicarbonate with their respective disorders. Place each value in the acidosis, normal, or alkalosis columns and see which two abnormal results align. This indicates the primary disorder. If all three are abnormal and in the same direction, it may represent a mixed disorder, such as a combination of respiratory and metabolic acidosis. When evaluating metabolic acidosis, calculate the anion gap using sodium, chloride, and bicarbonate. A raised anion gap suggests causes like methanol poisoning, uremia, diabetic ketoacidosis, paraldehyde or fenformin toxicity, iron or isoniazid overdose, lactic acidosis, ethylene glycol poisoning, or salicylate and solvent exposure. If the anion gap is normal, consider causes such as diarrhea, renal tubular acidosis, hydrochloric acid infusion, early renal failure, saline dilution, ureteropancreatic diversion, or pancreatic fistula. Another mnemonic is ROM, respiratory opposite, metabolic equal. In respiratory disorders, pH and partial pressure of carbon dioxide move in opposite directions. In metabolic disorders, pH and bicarbonate move in the same direction. Final thoughts: remember, the arterial blood gas is just a snapshot in time, always interpreted in the clinical context. What appears normal may still indicate significant pathology in a chronically unwell patient. Stay vigilant and use this systematic approach to guide your clinical decisions. Thank you for tuning in. If you find this content helpful, please like, share, and subscribe. This is the Everything Surgery Podcast, where we dissect the extraordinary.